Hello, and welcome to part two of the urinary system. Here is where we take a closer look at the function of the kidneys, and then we're also going to look at how urine is formed, and lastly, look at some homeostatic imbalances of this urinary system. Here's a nice slide that acts as a sort of overview of what we've talked about so far. We'll start at the top here, looking at filtrate. So recall that the purpose of the urinary system is to filter blood, and we can see that blood coming in on the upper left. And we see that the blood then moves into the glomerulus, which then produces filtrate into the capsular space. After that, our filtrate moves through the proximal convoluted tubule, through a descending and ascending nephron loop, and then into a distal convoluted tubule. From there, our filtrate has changed dramatically, where it then starts turning into urine. Here we move through the collecting ducts and end up into the medulla of the kidney. And these collecting ducts then lead into a papillary duct, and these papillary ducts then lead into the calyces. So at this point, we have a substance called urine, and we also switch to a sort of gross anatomy, something externally visible as well. So we see at the papillary ducts, those releasing into the minor calyx. Urine then goes into the major calyx and into our renal pelvis. From there, the urine travels down the ureter, empties into the urinary bladder, and from the urinary bladder, the contents are eliminated by the urethra. So that's just an overview of some of the anatomy we've talked about. Let's look today, we're going to focus more in depth what's happening at this glomerulus and also the tubules, and see how filtration is occurring. So in the function of the kidneys, specifically the nephron, we have three main activities: glomerular filtration of blood plasma, tubular reabsorption, and tubular secretion. So in this diagram above, we see a renal corpuscle on looker's left, and we see that filtrate entering the glomerular capsule, and that's what we mean by filtration. Then we move along to the tubules, and we see tubular reabsorption is going to happen. So some of those substances are going to be reabsorbed back into the bloodstream. And then we have tubular secretion, where once again things go from the blood back into a renal tubule, thus making urine. So let's take a closer look at each one of those three steps. Let's look at glomerular filtration. Well, just some general overview. It is blood pressure that produces that glomerular filtrate. And so our main focus is today, later on, we see how is that pressure affected, and how and what factors move substances from the blood into the capsular space. Well, we're talking about 20% of plasma being filtered, and in an amazing way, plasma gets filtered 60 times a day. That means the total content of plasma in the body. So the kidneys do a phenomenal amount of filtering of blood plasma. As we can see on looker's right, we recall the last time that the glomerulus is covered in podocytes, and we also have these filtration slits as well, and that's going to prevent the movement of large molecules. So this filtering can be enhanced by how thin the membrane is, or the surface area as well. And as a general rule of thumb, the blood pressure of the capillaries in the glomerulus is high, and that's thanks to a small size of the efferent arteriole. So in other words, that smooth muscle is going to sort of choke it off a little bit and create a sort of pressure buildup. And so later on we talk about how efferent and afferent arterioles are able to constrict and dilate. Let's take a closer look now at that filtration membrane. If we observe the diagram in the upper right, we see that the capillary is shown on looker's left, and the capsular space in yellow is shown on looker's right. You might recall that we have filtration slits in that region, and we also have fenestration, those pores, in other words. So this filtration membrane is a porous, thin membrane, and it's also negatively charged. It's going to be formed by the glomerulus and the capsule. And we can see here that we have some endothelium. This endothelium is fenestrated again, and that fenestration is going to allow plasma and dissolved substances to be filtered, but also restricting the passage of large structures. And when we say large structures, we're talking about things like very large leukocytes. We'll see a picture of those later on. So this porous membrane restricts the passage of large plasma proteins, but it also allows smaller structures to pass through, and that's thanks to this basement membrane. So the main principle of filtration is to force fluids and solutes through that membrane by pressure. And that's going to happen, it's the same glomerular capillaries as capillaries anywhere else in the body. Same process. Let's take a closer look now at some net filtration pressure. So as we said earlier, this filtration pressure is, sort of constant. We need some sort of overlying pressure that's going to provide a net filtration pressure. So we see in this diagram, in the end result, we have 10 millimeters of mercury out. So this overall combined net pressure is going to move filtrate out of the glomerulus and into the capsule. And so this overall pressure we might term as net filtration pressure, NFP. And that's going to be the difference between the blood's hydrostatic pressure within the glomerulus and the osmotic blood pressure and the fluid pressure within the capsular space of the renal corpuscle. Let's take another look at that image. Here we see an image that is sort of enhanced and shows these substances. So again, on the upper left, here we see that filtration membrane showing those larger molecules shut out, so to speak, of filtration, where these smaller molecules will move in. Here is that afferent arteriole. If you have a close look at that capillary, we see that blood, we might recall, is made up of many, many substances, and they did a good job showing those substances moving through the bloodstream here. Well, also we see how in this capsular space it has captured tiny solutes. Notice how these large leukocytes, erythrocytes, and larger proteins are left out of that capsular space. So we're talking about net filtration pressure, and again there's that equation up in the upper right showing that net 10 millimeters gained. This blood pressure within the glomerulus pushes water out, and it also pushes some dissolved solutes out of the glomerulus, and that's going to give us a glomerular hydrostatic pressure, also summarized as HPG. Here's showing that HPG. This is also shown in this diagram as BHP. So here we see that blood pressure. That's a large net force of 60 units of pressure outwards. The next sort of pressure we see is the osmotic pressure. There is an osmotic pressure exerted by the blood, and that's due to the dissolved solutes contained within it. Most notably, this comes from plasma proteins or colloids. So again, we have a factor of osmotic pressure, and here it is shown as COP. Notice how COP is working in the opposite direction of the blood hydrostatic pressure. And then our third source of pressure is the capsular hydrostatic pressure. That's going to be the pressure within the glomerular capsule, and that's due to the amount of filtrate within the capsular space. So together, once we look at all the forces and see what cancels out, we get an overall net filtration pressure of 10 units. What happens then is this net filtration pressure then leads to a GFR, a glomerular filtration rate. So this rate is going to be called the rate at which the volume of filtrate is formed. And we're going to express that as a volume per unit per time. So glomerular filtration rate. So again, that's going to be the amount of filtrate formed in all the renal corpuscles of both kidneys, and that's again told per minute. As a general rule of thumb, the average adult rate is 120 to 125 milliliters per minute. And homeostasis requires that GFR is constant. You might recall that we're looking for a delicate balance in the human body. So if we have too high of GFR, then useful substances are going to be lost due to the speed of fluid passage through the nephron. If that GFR is too low, then we have important waste products that might not get removed from the body. So then that net filtration pressure we talked about before is going to have an influence on the glomerular filtration rate. That means that filtration is going to stop if the blood hydrostatic pressure drops to 45 units. And these kidneys function normally when the mean arterial pressure is somewhere between 80 to 180 units of pressure. So, in summary, glomerular filtration rate is going to be affected by the net hydrostatic pressure, net filtration pressure that we discussed earlier. This slide serves to show how we regulate the glomerular filtration rate. And we see a graph. Let's familiarize ourselves with this graph. On the y-axis, we see flow expressed in milliliters per minute. And on the x-axis, we're looking at pressure increasing as we go outwards. And then we have a trend line shown here in red that suggests renal blood flow. So really what this graph shows is a sort of repeat of what we talked about on the last slide, and that is on Looker's left, we're going to get insufficient urine production because of the low blood pressure. We're also going to get low flow as well. You might recall that we mentioned that good blood pressure is going to be somewhere between 80 and 180 units. And so we see a sort of normal or reasonable GFR in that normal pressure range. Then we see with a higher blood pressure, we're going to get excessive urine production, and that's going to be shown on the increasing trend on the red line. And notice that the glomerular filtration rate drops off with that higher pressure. So again, GFR gets regulated such as to provide a homeostatic balance. So what controls this GFR? Well, we have three main mechanisms. We have renal autoregulation, neural regulation, and hormonal regulation. So let's go ahead and look into each one of those three. And here we take a closer look at that renal auto-regulation of GFR. The diagram on Looker's left is showing homeostasis. In other words, a homeostatic imbalance is on the upper left. We see that receptors detect this change in GFR. We send that to the control center, the juxtaglomerular apparatus, and that's going to release some output, decreased secretion of nitric oxide, and that's going to affect those arterioles on the nephron. It's going to result in a decrease in GFR, which brings us back to a normal homeostatic balance. Well, let's look at two main factors of affecting GFR. The first is the myogenic response, and the second is the tubuloglomerular feedback mechanism. So this myogenic response is going to be a sort of response involving contraction and relaxation of smooth muscle in the wall of the afferent arteriole. That means the arteriole going towards the nephron. That's going to reduce the diameter of the arteriole, returning the GFR to its previous level within mere seconds. So in summary, think about it as sort of pinching off a garden hose. As we pinch off the garden hose, we affect the flow of water through that garden hose. The next form of renal autoregulation is going to be the tubuloglomerular feedback mechanism. And this mechanism detects increased sodium chloride levels, salt levels in other words, within the tubular fluid of the juxtaglomerular apparatus. And this is going to aid in the regulation of normal glomerular blood pressure. And so here we see that the afferent arterioles are going to constrict and therefore reduce the GFR. This is done thanks to macula densa cells. These are able to detect the difference caused in these sodium chloride ions, and that's going to release a vasoconstrictor from the juxtaglomerular apparatus. So in summary, GFR is affected through the kidneys through renal autoregulation. And then another way we might regulate GFR is through neural regulation, that is, nervous structures. Here we see blood vessels of the kidney are supplied by sympathetic fibers of the nervous system, and that can cause vasoconstriction of those afferent arterioles. When we're at rest, our blood vessels inside the kidney are maximally dilated because sympathetic activity is minimal. So this is where the previous slide, renal autoregulation, is going to prevail. Then if we have a stimulus with moderate sympathetic stimulation, both the afferent and efferent arterioles constrict equally, and that's going to decrease the GFR. And then if we have extreme sympathetic stimulation, vasoconstriction of the afferent arterioles is going to reduce GFR even further. And the result of that reduced filtrate coming out into the capsular space is going to lower our urine output, also permit blood flow to other tissues. So in summary, in neuroregulation of GFR, we have sympathetic stimulation decreasing the GFR through afferent arterial vasoconstriction, and also we're going to get surface area decreasing on the glomerulus. So our third way that we might influence GFR is through hormones, hormonal regulation of GFR. We might recall from our discussion in the endocrine system that hormones in the endocrine system are a key component of maintaining homeostatic balance. Let's look at two specific hormones. First, we see that angiotensin II reduces GFR, and that hormone is a potent vasoconstrictor that's going to narrow both afferent and efferent arterioles, and thus the result is we reduce GFR. Another important hormone is going to be ANP, that is going to be atrial natriuretic peptide, and that's going to increase GFR. That results in stretching out of the atria in the heart, and that occurs with an increase in blood volume caused by that hormonal release. Similarly, this is going to relax the glomerular mesangial cells, and that's going to increase capillary surface area. The result of that is also increasing GFR. So in summary, with ANP, we're going to get ANP released from cardiac muscle cells, and these are going to go into the the bloodstream, and affect the chamber of the heart. That's going to cause a relaxation of that afferent arteriole, inhibition of the renin release, and that relaxation of mesangial cells. The whole end result is that we get an increase in the filtration membrane surface area and an increase in GFR. And recall that an increase in GFR is going to result in more urine volume and decreased blood volume. So in summary, the flow of GFR, in other words, the rate at which filtrate comes into the glomerular space, is affected by the renal autoregulation, neuroregulation, and hormonal regulation. We now turn our attention to the second topic of our discussion on filtration, and that is tubular reabsorption. So at this point, we're moving away from the glomerulus and Bowman's capsule, and we're looking at tubules, such as the proximal convoluted tubule, or the nephron loop, or the distal convoluted tubule. Some of these substances that are subject to this reabsorption include things like sodium, potassium, bicarbonates, calcium, and water. Here, sodium is going to be our important pivotal role in the process of reabsorption. So you might recall from the last section that normal GFR at resting rate is actually quite high. And so the volume is so high that in a half hour, we are able to filter total blood plasma. So that's how we get that phenomenal statistic of filtering 60 times a day. And so the nephron must reabsorb 99% of that filtrate, since we're passing so much of it through. And in the slide below, we can see two main routes of reabsorption, one being a paracellular route between those tight junctions of the cells, and the second is transcellular, where we're actually moving substances through the cell membrane. Let's look a little bit more at this tubular reabsorption. And this discussion will be framed around the location where this reabsorption occurs. As a general overview, this is a nice slide shown out of the textbook. Again, as a general rule of thumb, notice we have the paratubular capillary on the upper part, and we have our tubule on the lower part. Again, notice how we can visualize some of these small solutes shown with the yellow dots, and notice we can visualize these larger erythrocytes that stay behind in that capillary. So let's take a closer look at this reabsorption in the proximal convoluted tubule. So that means we're dealing with reabsorption coming right when this filtrate has exited the glomerulus. We'll start by getting our bearing straight, that on looker's left of the diagram, we're looking at filtrate in the lumen in the tubule. That means the empty space inside that tubule. And on looker's right, we're seeing the paratubular capillary. Notice we're watching what's happening with these ions, such as sodium and potassium and chloride. Let's focus on sodium in this slide. We see that sodium is being reabsorbed along most of the renal tubule, and again, the majority of that is going to occur, that absorption of sodium occurs in the proximal convoluted tubule. This sodium is transported down its concentration gradient across the luminal membrane, and that's going to be done by facilitated diffusion because it's going against its concentration gradient. We're going to have sodium-potassium pumps helping out with that facilitated diffusion. Additional sodium is reabsorbed and potassium gets excreted, and this can be influenced by aldosterone, that hormone that is, binding to the principal cells and thus increasing both the number of sodium carriers and also the number of sodium-potassium pumps. We might recall that ANP is also a hormone as well. That's going to inhibit both the reabsorption of sodium and the release of aldosterone. And that's going to result in an increased excretion of sodium and water through the urine. Now we move along the anatomy. We see about how reabsorption occurs in the loop of Henle. We might recall that this nephron loop or loop of Henle has thick and thin portions to it. You might recall that thick limb is created by thicker epithelia. So at this thicker limb, we have sodium, potassium, and chlorine symporters that reabsorb these ions. Here we can see that symporter there. The potassium leaks through the potassium channels back into the tubular fluid, leaving the interstitial fluid and blood with a negative electrical charge. Then we see the vasa recta shown on looker's right. Cations, that is, are going to move passively to that vasa recta. And although about 15% of the filtered water is reabsorbed in the descending limb, little or no water is reabsorbed in the ascending limb. In this ascending limb, we're going to get substances like sodium, chlorine, and potassium absorbed, as well as some calcium and magnesium. So overall, in summary, in this nephron loop, water gets reabsorbed through osmosis, and we have active transport of those important other ions. Now we turn our attention how reabsorption occurs in the distal convoluted tubule. This distal convoluted tubule is not very permeable to water, so we're not so much concerned about water reabsorption here, unless that is we're affected by ADH. The main substances we're looking at here is sodium, chlorine, and calcium ions moving through those principal cells. So again, we see these symporters, we see these embedded channels in the membranes of the cells that allow the sodium and chloride to do this reabsorption process. The distal convoluted tubule serves as the major site where parathyroid hormone is going to stimulate the reabsorption of calcium ions. By the way, it's also worth noting the collecting duct. The collecting duct does a little bit of reabsorption as well. We're going to get water reabsorbed in our collecting duct. Also a little bit of sodium, potassium, and bicarbonate and chlorine ions. So in summary, let's go ahead and back up a little bit on this reabsorption. So I'll use this diagram up here. In summary, in the proximal convoluted tubule, we're going to get substances like those primarily absorbed sodium ions get reabsorbed. All nutrients get reabsorbed. Things like glucose, amino acids, and vitamins get reabsorbed. Chlorine, potassium, and water, and even some lipid-soluble solutes can get reabsorbed here at the proximal convoluted tubule. We then move down into the nephron loop. In our descending limb, we only get the reabsorption of water, but on the ascending limb, we're going to get sodium, potassium, and chlorine, and then also some calcium and magnesium ions. In our distal convoluted tubule, we get sodium chloride and calcium ions being uptake. And then in the collecting duct, we're going to see the reabsorption of sodium, potassium, chlorine bicarbonate, and water solutes. Okay, so let's now take a closer look at one hormone, anti-diuretic hormone. ADH is going to increase water permeability of those principal cells, so it regulates the facultative water reabsorption. So what's happening is that in these membranes, we have aquaporins installed. Aquaporins are going to be transport proteins that perform the transcellular transport of water. These aquaporins are going to be in the luminal membrane and are permanent in that number, remain permanent in number as well. So this osmotic movement of water following sodium out of the proximal convoluted tubule is called obligatory water reabsorption. And so this is related to our ADH. What happens is ADH is going to stimulate the insertion of aquaporin channels into the membrane. So that means water molecules move more rapidly. Then when osmolarity of plasma and interstitial fluid increases, even more ADH is secreted and this facultative water reabsorption increases. So facultative water reabsorption is the process by which solute concentration of the tubular fluid increases due to the tubular reabsorption response of ADH. So in summary, what happens is with increased ADH within the blood, that's going to result in the production of a lesser volume of higher concentrated urine, whereas ADH results in the production of a greater volume of less concentrated urine. So now we turn our attention to the third main process after GFR filtration rate, after reabsorption. We now turn our attention to tubular secretion. And so notice that we're now at the end of the nephron. By the end of the distal convoluted tubule, 95% of solutes and water have been reabsorbed and returned into the bloodstream. But we still have some materials that are still going to be transferred from the blood into the tubular fluid. So in a sense, tubular secretion is going to be the reverse of reabsorption. And so this tubular secretion is going to move selected substances such as hydrogen ions, potassium ions, or urea, creatine, and other organic acids and bases. These are going to move from the peritubular capillaries through the tubule cells and back into the filtrate. That means the urine eventually contains both filtered and secreted substances. Why might we have tubular secretion? One purpose is disposing of substances, such as drugs or metabolites. Another purpose is to eliminate undesirable substances or end products that have been reabsorbed by passive processes. Urea is a good example of that. And then also we can rid the body of excess potassium ions, and that's created with those principal cells. So in summary, we see that GFR and is affected by, I should say, filtration in general is affected by the GFR, tubular reabsorption, and then tubular secretion. And then we now turn our attention to how urine is created. Recall that coming out of that collecting duct is going to be filtrate that has now been turned into urine. In this diagram, we see different samples showing dilute urine on looker's left and a more concentrated urine on looker's right. So we're going to see what affects this urine concentration and also the volume of the volume of the urine. The rate at which water is lost from the body depends mainly on ADH, antidiuretic hormone. That's going to control the water permeability of principal cells in the collecting duct and also in the last portion of the distal convoluted tubule. Again, ADH is an important hormone for homeostatic balance in the human body. And the formation of dilute versus concentrated urine involves long juxtamedullary nephron loops and collecting ducts as well. So let's look on how urine production relies on two specific mechanisms, the countercurrent mechanisms, that is the countercurrent multiplier and the countercurrent exchanger. Here we see the countercurrent multiplier. Notice how we are observing what's happening in the nephron loop at this location. So let's back up a bit and think about ADH again. Recall that ADH is reliant upon the concentration gradient of sodium and chlorine ions in the interstitial fluid surrounding these nephron tubules. So in this counter current multiplier, blood osmolarity should be about 300 osmolarity. The descending limb is very permeable to water, and filtrate osmolarity increases. The ascending limb is impermeable to water, but solutes can leave the filtrate osmolarity decreases. So what this is then is a positive feedback mechanism. So in this positive feedback mechanism, tubular fluid reverses direction as it moves through the descending and ascending limbs of this nephron loop. It's going to increase salt concentration within the interstitial fluid. As we mentioned before, this descending loop is permeable to water, but it is impermeable to salt movement. Therefore, water is able to move out of the tubular fluid, but the salt is retained within it. Then we arrive at the ascending limb that is impermeable to water, and therefore it actively pumps out salt out of the tubular fluid and retains it in the water within. And now we see that another way to influence the concentration of our urine is going to be countercurrent exchanger. This is going to be a process where the vasa recta helps maintain the concentration gradient through an opposite directional blood flow within parallel capillaries, and we're also going to exchange salt and water in this system. So we might recall that these structures are surrounded in capillaries or tubes called the vasa recta. So the vasa recta surrounds the tubule and is going to preserve the medullary gradient while removing reabsorbed water and salts. Here we have an image showing that vasa recta on looker's right and the collecting duct in the middle. The formation of concentrated urine, that can be, the urine can have a concentration up to 4 times greater osmolarity than plasma. You might recall in this collecting duct we have principal cells. So it's possible for principal cells and ADH to remove water from urine to that extent if interstitial fluid surrounding the loop of Henle, as long as it has high osmolarity. We have these long juxtamedullary nephrons that make that possible. And again, we have small channels installed in there. The sodium, potassium, and chlorine symporters reabsorb sodium and chlorine from the tubular fluid to create an osmotic gradient in the renal medulla. When we're concentrating the urine, the cells in the collecting ducts reabsorb more water, and urea when ADH is increased. So one downside of the urea recycling is going to cause a buildup of urea in that renal medulla. So that is going to be our formation of concentrated urine. Let's look how dilute urine is formed now. When we say dilute, we're talking about having fewer solutes than plasma. That means about 300 osmolarity. Filtrate and blood should have equal osmolarity in the proximal convoluted tubule. We might recall that water can be reabsorbed in the thin limb of the nephron loop, but ions reabsorbed in the thick loop of Henle create a filtrate more dilute than plasma. This can actually be 4 times more dilute as plasma. Also, it's noteworthy that principal cells do not reabsorb water if ADH is too low. So in summary, urine can be both concentrated and dilute. When we are overhydrated, for example, ADH production decreases and the osmolarity of urine falls low. If aldosterone is present, then the distal convoluted tubule and collecting duct cells can remove sodium and other ions from the filtrate, making that urine more dilute. When we are dehydrated, the posterior pituitary is going to release large amounts of ADH, and the solute concentration of urine may rise very high. We now turn our attention to the topic of diuretics. And when we say diuretics, we're talking about certain substances that can slow reabsorption occurring in the kidneys, reabsorption of water, that is, and cause diuresis, that is, the increased urine flow rate. When we talk about diuretics, we're talking about things like caffeine, alcohol, and certain prescription medicines. There's a variety of ways that these substances do their work, but the most potent ones have an influence on the loop. Loop diuretics, such as furosemide, inhibit the symporters in the thick ascending loop of Henle. And at this point, we switch gears and we now talk about sort of the gross anatomy again. We're looking back on a non-microscopic level, and we're looking at urine storage, how urine is transported, and how that urine gets eliminated. So recall that urine does not have any bacteria. We did not see any bacteria, or at least in a normal situation. So urine is a sterile excretion, and that's going to be composed of filtered and processed blood plasma. This urine is going to be mostly water, about 95% water, and about 5% solutes. So what ends up in this urine is going to be solutes such as salts, nitrogenous wastes, hormones, drugs, and some other ketone body products. One might notice we have variations in the daily intake, or output, I should say, of our urine capacity. This can be affected by our diet, our body temperature, other diabetes, or heavy sweating and vomiting can affect our urine output. This urine is going to range from about 4.5 to 8 pH with an average value of 6. And the density can fluctuate. We'll talk about that in a short few later on. But right now, we'll talk about some gross anatomy. We see that the urine drains through papillary ducts into minor calyces and join in to become major calyces that form the renal pelvis. You might recall from the renal pelvis, then the urine moves down these ureters and then into the urinary bladder and finally out through the urethra. So let's take a closer look at some of those functions. Before we get into those functions, let's look at the bladder anatomy. Here is a frontal view of that bladder. We see that the bladder is a hollow, distensible muscular organ. It has a capacity of about 700 to 800 milliliters. Perhaps you can see where the ureters come in and enter into the bladder. So this bladder is an expandable muscular retroperitoneal organ, and that's going to be a reservoir, holding reservoir for our urine. We see a structure called the trigone of the bladder. That's going to be a smooth, flat area bordered by 2 ureteral openings and 1 urethral opening. We also have some folds in there, mucosal folds called rugae, allow for the bladder to undergo an even greater distension. Then we have inside here 3 layers of smooth muscle forming a muscularis layer, collectively referred to as the detrusor muscle. Let's take a closer look now at the anatomy of the urethra. So this urethra is going to be lined with epithelia. It's also going to be lined with fibers, and it's going to be a muscular tube, so to speak, and it's going to be coming out of the urinary bladder. In this diagram, we see the urethra for the male and on the upper right, and in the lower left, we see the urethra structure for female. There are some slight differences. We'll probably get into some of those more specific differences when we talk about the reproductive system. But let's look into the urethra. The urethra is an involuntary muscle. I should say the superior, that is the internal urethral sphincter, is involuntary muscle. And then we have below that the external urethra. That's going to be a voluntary sphincter, and that's formed by skeletal muscles on the urogenital diaphragm. And so the idea is that we must consciously release our external urethral sphincter, and then the internal urethral sphincter follows in the involuntary manner. What we then get is a process called micturition, or urination, or voiding the contents of the bladder. And what happens is we have stretch receptors embedded into the walls of that bladder that signal the spinal cord and the brain that it's time to release the contents. That happens when volume exceeds about 200 to 400 milliliters, depending on the person and their age. Impulse is sent to this micturition center in the sacral spinal cord. We trigger a reflex. And what happens is parasympathetic fibers cause the detrusor muscle to contract. External and internal sphincters muscles will relax then. The filling of that urinary bladder causes a sensation of fullness that initiates a desire to urinate before that reflex actually occurs. So again, we have conscious control over that external sphincter. So it's noteworthy that the autonomic nervous system and the somatic nervous system both control the storage of urine and also the expulsion of urine. So that means the cerebral cortex can initiate a micturition, or it can delay the occurrence for a limited period of time. Lastly, we turn our attention in this study of the urinary system to homeostatic imbalances. And you might recall that in lab class we are working with dialysis tubing. And so that tubing is a semi-permeable membrane. Well, here we see the process of dialysis. And dialysis is an artificial way to have the kidneys work, so to speak. Dialysis is the separation of large solutes from smaller ones through the use of a selectively permeable membrane. In other words, that dialysis tubing. We can get filtering blood through an artificial kidney machine called hemodialysis. This procedure filters the blood of wastes, the waste inside blood, and it's going to also add nutrients. So therefore, dialysis is going to be a treatment for renal failure. So having said that, we can get chronic renal failure. This refers to a progressive and generally irreversible decline in glomerular filtration rate, and that can result in a variety of homeostatic imbalances. On the lower right, we see polycystic kidney disease. We can see from the image on the lower right that we have multiple cysts on those kidneys. So that's what we mean by polycystic, poly being many. And with all these thousands of cysts on the kidney tubules, that kidney becomes dysfunctional and can cause renal failure. Another homeostatic imbalance with the kidney is going to be glucosuria. So glucosuria is going to be the excretion of glucose into the urine. If it's working properly, glucose should be totally reabsorbed in the proximal convoluted tubule. But if the blood glucose level exceeds transport maximum, such as diabetes, then glucose will be excreted in the urine. So this glucosuria is going to occur when reabsorption cannot occur fast enough. And this, in addition to the last one, are both caused by a genetic predisposition. Another problem that might occur with the kidney is a kidney stone. If one ever talks to a person who has quote-unquote passed a kidney stone, they'll describe it as an extremely painful situation. And here we see that kidney stone passing through the ureter. And something not shown is that that kidney stone has jagged, very sharp edges. And that's because the salts have become crystallized. So the salts that are inside the urine can crystallize, they can precipitate and solidify into renal calculi, also called kidney stones. These can block the ureter and cause further pain, but another way to rid these is to shock them with lithotripsy. Litho meaning rock, so in other words, we might send some ultrasound waves in there to break up that kidney stone. Here we have another imbalance. Nephroptosis is an inferior displacement of the kidneys. It often occurs in thin people. You might recall that those kidneys are coated in a fibrous capsule, and that fibrous capsule is supposed to bond and adhere to the peritoneal walls. When this system fails, the kidney might shift, and this can be a dangerous situation because ureters may get kinked or blocked, and therefore we might have a blockage of urine flow. If these kidneys do fail and we need a new kidney, here is an image showing a kidney transplant. In this diagram, we see the location of our diseased kidneys, and we see that in here a donor has donated a kidney, and that's placed in the pelvis through an abdominal incision. The renal artery, renal vein, and ureter of the donor kidney are connected to the corresponding structure in the recipient. What happens, though, is this transplanted kidney is going to be considered foreign tissue, so the body is going to reject it. Therefore, immunosuppressant drugs are regularly administered to suppress the immune system's activity. And the recipient of this kidney may need to take these drugs for the remainder of his or her lifetime. And then lastly, we end with a common homeostatic imbalance in the urinary system, and that is a urinary tract infection, a UTI. We can define a UTI as describing either an infection of part of the urinary system or possibly even the presence of large numbers of microbes in the urine. So we're going to have inflammation of the urethra. We're going to have inflammation of the bladder and the kidneys. You can even get inflammation of the renal, pelvis, and its calyces. So that means a urinary tract infection can occur anytime bacteria or even fungi enter and multiply within the urinary tract. It is noteworthy that women are more prone to urinary tract infections than men. Finding a solution to a UTI is somewhat enigmatic sometimes. A urinalysis is going to be a common diagnostic procedure to prevent a UTI from occurring. So that does it for the concepts of part 2 of the urinary system. As always, please refer to the textbook for any more detailed information of subjects you'd like to look more in depth into. Thank you for your attention. Our next topic we'll talk about next week is going to be the reproductive system.